Dear colleagues, dear friends, it's a pleasure to welcome you this afternoon for this new skill-based ENS section webinar. We are truly proud to welcome you. You are this afternoon more than 700 to register. It's truly impressive, and it's in fact extremely important for us to have your feedback and to see that you are very active and motivated to participate to our webinars. I would like to wish you the best for this new year, and of course, stay safe in this difficult sanitary situation. I wish you many projects, very interesting projects, and as you have seen, the ENS skill-based section has many projects we have seen in the previous mail, another way to interact all together with case quiz after case discussions. I hope you enjoy all those topics. Today, we will speak about craniopharyngiomas, and we have a very impressive panel of speakers. We have Professor Marcos Tatagiba from Tübingen, who will discuss with us the transcranial approaches. We have the Professor Juano from Lyon, who will speak on the Trans-lamina terminalis approach. Then Professor Fröhlich from Paris will have the opportunity to discuss the choice of the approach for retroinfundibular and third ventricle craniopharyngiomas. Then Luigi Cavallo has made for us a recording of his presentation because he cannot stay with us this afternoon, but we will listen to him. He will speak about the endonasal route for craniopharyngiomas with intraventricular extension. Then Professor Messerer from Lausanne will discuss the transphenoidal approach, indications and limits. Then Professor Schröders from Westphal will discuss if we have to sacrifice or not the stalk. And finally, Emmanuel Juano will present one interesting project, which is the European network he would like to build on craniopharyngiomas. So it's this evening, and we'll give the floor now to Marcos Tatagiba. Just a few words before I would say hello to Professor Capabianca. We have the chance to have him with us this evening. So please, Marcos, up to you to discuss the transcranial approaches, please. Marcos, you are muted.
Marcos, you are muted.
Okay, now you
perfect.
Perfect. I'm sorry for that. I didn't want to disturb the chairman, so that was the reason. It's a great pleasure to be with you this afternoon in this first webinar of 2021. We hope that this will be a fantastic year for all of us. So I'm not coming into details what craniopharyngioma is. I guess you know. I'm coming straight to my talk on microsurgery of craniopharyngiomas using transcranial approaches. Actually, all approaches are transcranial. In order to get inside the cranium, we have to do a transcranial approach wherever this approach is located. But of course, we call transcranial approaches those approaches located above the skull base and not using the transnasal area. As you know, craniopharyngiomas arise in this area here of the pituitary stalk. This is the most common area. This is a midline tumor. And that's the reason why most approaches use the midline to come there, but not exclusively. So the very traditional and most used approach, the transphenoidal, is pretty much discussed in many conferences, and it will be discussed and demonstrated here also quite extensively. So I'm gonna talk on the real transcranial approaches. The first one that can be used for some kinds of craniopharyngiomas, which are going very far into the third ventricle, is the transcallosal approach for particular cases. Otherwise, we can say the anterior skull base approaches. These are the most common ones, divided into pteronal approach, frontal orbit zygomatic, subfrontal approaches like bifrontal craniotomy, subfrontal craniotomy, interhemispheric approach, or frontolateral, supraorbital. There are plenty of possibilities. And also posterior skull base approaches that has been described and performed in particular cases, so transpetrosal ones. So I'm not coming too much into details in each approach. It would take too much time. I'm gonna concentrate to the most common approaches we use. So the most common approaches we perform, they are located on this area. And actually in the past, because this tumor is a tumor of the midline, the bifrontal craniotomy had been used for a long period. Now, more and more lateral approaches have been performed, like the supraorbital or frontolateral approach. And another one that it's used very frequently is the subfrontal, using the midline to go interhemispheric to the lamina terminalis. And then more sophisticated approaches like the frontal orbit zygomatic. I personally don't like so much this approach, and I almost never use for craniopharyngiomas. So the approach of preference in our hands are the frontolateral or supraorbital approach and the subfrontal interhemispheric. These are the approaches we use in most cases if we are gonna perform a transcranial approach, if we're not going to do transnasal. And in some particular cases, also the transcallosal. So the so-called supraorbital or frontolateral approach has been very much popularized by Professor Pernetsky, you will remember. And this is a very simple approach, very easy to learn, easy to do. It takes 15 minutes from skin incision until you are opening the dura mater. It can be used for several pathologies, not only for craniopharyngiomas. And it gives you a very nice view into the interoptic area, also triangle between the carotid and optic nerve. You can go through the lamina terminalis, and you can go far behind up to the basilar arteries and so on. And you can do the approach using such a skin incision behind the hairline, as you can see here, the skin incision with the patient positioned about 30 to 45 degrees to the contralateral side, skin flap, the craniotomy, and so on. Or you can use eyebrow incision as well. It can, in particular cases, it can be a very good solution. This is what we expect to see when we perform this approach. In these graphics, a little bit bigger than what we do usually. And this is a real case. We have done this small supraorbital approach for this craniopharyngioma here. And you see, we expose the optic nerve, carotid, and then you can check whether the craniopharyngioma can be approached between the optic and the carotid. or between both optic nerves, or whether the craniopharyngioma is completely inside the area of the third ventricle, so that you must open the lamina terminalis to get into this pathology. And this approach will be demonstrated more specifically later on. But here, this is just to show what we can reach using this small opening located at the supraorbital area. So we can use both hands to dissect. You see, with one hand, we hold the tumor. With the other hand, we dissect the surrounding tissue in order to protect the hypothalamus. We know that craniopharyngiomas may give some finger-like projections into the hypothalamus, so that not always we can perform a total removal. So this is the final view after performing this approach. Now I'm gonna show, here is the patient afterwards. This is another case. We use the same approach to enter. You see there is a huge extension into the ventricle. We could have done a puncture via the transcallosal approach, but it's not necessary. So here again, exposure of the optic nerve. You see also the olfactory nerve, carotid. You see the optic nerve is yellowish. This has a yellow color, is a slight discoloration produced by the tumor. And now you can visualize already this part of the craniopharyngioma located at the suprasellar area. So we can enter this space. This is the carotid optic triangle. And then we expose these structures. We can see the contralateral posterior communicating artery. Then puncture of the cystic component. And then the same technique, we hold the tissue with one hand, with the other hand, we dissect the tumor from the surrounding area. So here the ipsilateral PCOM, and at the end of surgery, you can have a nice view to the basilar artery and posterior circulation complex, pituitary stalk. If possible, we try to preserve it, but this we know is a challenging task. And then when we have removed the tumor outside of this area, we can still enter the lamina terminalis and continue our dissection. If you are coming from the interhemispheric approach, you have a more direct view to the lamina terminalis. On the other side, the approach is more time consuming. You have to dissect the anterior cerebral artery and communicating artery. So using the frontolateral approach, you can also do the same job. You see here, now we are dissecting the craniopharyngioma from the surrounding tissue. As I told you, there are some finger-like projections into the hypothalamus, and not always we can remove the craniopharyngioma totally, or we may risk some hypothalamic function. So, but at the end, if you do careful and patient's dissection, you may reach a very good result and perform a complete removal. So this now you can appreciate more easily the structures are coming, and all patients receive ophthalmological examination before and after surgery, so to assure that these procedures did not affect the optic system. And but we know it's very tough. There are craniopharyngiomas, they are easier to remove. Some others are extremely difficult, calcified, sticking, and produce recurrence very frequently. There are different types on craniopharyngiomas, biologically speaking. So this is the end of surgery. You see a big hole, but it doesn't mean that this will affect the optic nerve. This has produced by the tumor itself. So another video I will not show to you. It is similar to the first one. Then we can also choose the transcallosal approach. I'm not showing the whole surgery here. We prefer to position the patient like this in order to have a horizontal plane to enter the corpus callosum. Or sometimes this is also a very elegant way, is that you make the puncture of the cyst part of the craniopharyngioma using endoscopes. So you can use this transcallosal approach to enter this area and to remove the craniopharyngioma, or you can make a puncture of the cyst using endoscopes and just to produce some release of the pressure, and then you can remove the craniopharyngioma via transnasal approach or other approaches. So, and finally, let me spend some words talking about the posterior petrosectomy. I personally don't use it, but my friend Sebastian, he seems to like this approach for particular parts of craniopharyngiomas which are going retrochiasmatically. This is a more complex approach. This should be used only for very specific cases. Otherwise, the anterior skull-base approaches are the preferable approaches in most cases. And here, this posterior petrosectomy, what we do is we do a borehole in this area, and then we perform a craniotomy like this and drill away the mastoid in order to reach this area here of the retrochiasmatic region. So this is just to mention that. We can discuss this later on. So summarizing, particularly the anterior transcranial approaches, they have the advantage to go through clean corridors in comparison to transnasal area. They are very easy to learn, the anterior transcranial approaches. The dissection from the surrounding tissue is feasible and not difficult because you can use both hands to do that. It still allows the use of endoscope. The patients recover very fast and they produce excellent aesthetic results. And last but not least, the very low risk of CSF leakage in these cases. Merci beaucoup. Thank you very much. It's a pleasure to be with you.
Thank you so much, Marcos, for sharing with us your impressive experience for managing those lesions. It's now time to give the opportunity to Emmanuel Joanneau from Lyon to discuss with us the Trans-lamina terminally approach. Please, Emmanuel.
Okay, you can see the screen?
Yes, perfectly.
Okay, so,
not yet in full screen mode.
So, good evening, everyone. We will focus on atrioventricular craniopharyngioma, and there is many of examples that have been given by Professor Tatashiba, and we will focus on Trans-lamina terminalis approach.
Emmanuel, just one point. We see two slides of you we are not truly in full mode. So if you would like to speak without the full mode, it will be maybe better.
I don't know. You see two screen?
Yes, we can see your next slide also. But if you present without the full mode, it will work and we will better see your. That's correct.
Yes.
Correct.
That's good. Yeah.
It's perfect. Thank you.
Okay. So the craniopharyngioma is for me a very interesting topic and very challenging topic. So I use this presentations many data we published last year with other team, and you all know that there is many kind of craniopharyngioma, and there is. I advise the student to read the paper and the work from the Spanish team, Ruth Prieto and José Pascual, that show you the different kind of craniopharyngioma you can have: cellular, supracellular, intraventricular, and pure intraventricular craniopharyngioma.
Emmanuel, can I ask you, sorry to interrupt you, to take your microphone?
Yeah, yes.
That's perfect.
Okay. So for pure intraventricular, the better sequence to locate, to have a good idea of the locations and the origin of the craniopharyngioma is the sagittal T2 sequence. And to locate the origin of the craniopharyngioma, you have to check the mammillary body angle, which is the angle from the third floor on the mesocephalum. And when the craniopharyngioma locates an origin from the intraventricular space, the angle is less than the normal range. That's normal is in between 50 to 70 degrees. So it's very important to decide and to design your surgical routes. So there is, to get inside the third ventricle, you already know that from the presentation of the Professor Tatajiba, there is several routes you can use: the transcranial, the transventricular, transfrontal approach, and the Trans-lamina terminalis. I will be very fast on the two first one. When you have a very huge craniopharyngioma, like in this case, there is hydrocephalus, and it's quite easy, and you can use this approach. You use a transfrontal, transventricular approach, and after you get inside the lateral ventricle and you dissect, and you get inside the third ventricle in between the fornix and the thalamus at the level of the plexus choroid. You have to cut the septal vein and you have a very good space, but it's quite dangerous, but you can get through the choroid, superior choroid tela, in between the internal vein, and you get inside the third ventricle to work. In many cases, when you have a huge tumor, the tumor gives you the space to work inside the third ventricle. And here is one example. And the most difficult, and you need to be trained for that, it's not so easy to remove the tumor. And the most difficult choice, you have to choose in between to do a radical removal or not. And it's really matter of experience. I mean, sometimes the tumor, it's quite easily removal, but sometimes the tumor stick too much, invade the hypothalamus wall, and you need to be safe and to keep in place some pieces of the tumor, like in this case. When there is no hydrocephalus, you can use a transfrontal approach, an interhemispheric transfrontal approach. I rather prefer to put the patient supine and the head neutral, and you perform an interhemispheric transcallosal approach. And after you get inside the third ventricle, it's the same. It's at the end, the same way that the transfrontal, but you don't get through the brain. And the most difficult part of the tumor to remove is the deepest part of the tumor. Like in this case, it was too sticky. I cannot control the dissection from the vessel, and there is an invasion of the third floor ventricle, and I was obliged to keep some pieces of the tumor. It's very important to preserve as much as possible the hypothalamus. So we will just focus a little bit on the Trans-lamina terminalis. You have the nice, all of you know the paper from Roton. Here is the optic nerve. Here are the optic nerve, the chiasma, the arterial landmark here, the anterior cerebral artery first segment, the anterior communicating artery, left anterior cerebral artery, and the lamina terminalis is a small, narrow space you can get through to get inside the third ventricle. So you can use a supine position. The head is slightly extended. If you do a right subfrontal approach, you turn left your head, but not that much. Or you can use a neutral position with a more interhemispheric approach. The surgical steps are quite easy. It's like for other cranial and anterior skull-based cranial approach. You need to look at the optic nerve. You need to open up largely the basal system to have a good CSF depressions. You open up the Sylvian fissure because you need to have all your arterial landmark and to have a good brain and frontal brain relaxations. And after, you just have to follow the optic apparatus, the right optic nerve till the chiasma, the left optic nerve, and after identifications of the right CA1, the anterior communicating artery, the left CA1. And after, you have all your landmark to locate the lamina terminalis and to get inside the third ventricle. So you can use, like in the video of Professor Tadajima, this a small window just to push. You open up the lamina terminalis and you just take a cotton, you push the upper part of the tumor to push down the tumor and to remove the tumor, walking in the interoptic space or the interoptico-carotid space. But it's not true intraventricular dissections and surgery. Here is a real live surgery. The optic nerve, the orbital, the Sylvian fissure was there. You just have to follow the optic nerve. You just have to dissect and to open up the Sylvian fissure. Here is the ICA. You just have to identify the right ICA, the left ICA, the anterior communicating artery, and the lamina terminalis is right there. It's for intraventricular, and you can remove intraventricular craniopharyngioma using this small window. You open up the lamina terminalis, and after you have, it's a piecemeal technique. You have to debulk your tumor, and after you just have to take your tumor and to identify the surgical plane, the dissection plane between the tumor and the hypothalamic wall. And sometimes it's like in this case, in this part of the surgery, it was quite easy to differentiate the tumor from the hypothalamus. It was not that easy from the anterior part. It's not so easy to expose the tumor. You don't have to push that much the optic apparatus. It's more difficult to identify the plane on the right side when you are coming on the right side. You can dissect the interoptico-carotid space. You identify the perforating artery, and after you push gently with a cotton to push your tumor midline and to remove as much as possible of the tumor. But it's sometimes quite tricky to have a good exposure on the right side. The floor was completely invaded by the tumor, so we need to stop the surgery. So don't push too much the surgery inside the third ventricle, because sometimes you can have a very bad outcome for the patients. But the most difficult to expose is the upper part of the tumor. I mean, here is the window you have, and you will have to work behind the cerebral anterior artery, above the cerebral anterior artery. So it's quite difficult to expose. You can use mirror, but it's not a good way. It's a very old-fashioned. You can use sometimes endoscope, but it's the most difficult to expose is the upper part of the tumor. So here is an example. I was quite happy after the surgery. I think that the surgery was radical, no ophthalmologic, no endocrine deficit after the surgery. But you need to be patient because there is, in many cases, invasions by the craniopharyngioma. You don't have all the control of the disease. And 1 year after, there was a cyst at the level of the infundibulum. I was thinking I was radical. It's not true. The disease is not so easy to control. And we control the patients with radiotherapy. And the patient is going well without any deficits. Another example, it's it's more difficult tumor because you can see here there is edema. You can see here there is brain hypothalamic invasion. So I decided to do a subtotal resection just to reduce the tumor. I keep in place some pieces of the tumor, and after we will do radiotherapy. So just take home message. For intraventricular tumor, you have to check the sagittal T2 MR, to MBM angles. You have to look about hypothalamic invasions, but because when there is edema, when there is diffuse contrast enhancement, not clear, probably it will have hypothalamic invasions. So pure Trans-lamina terminal approach is probably for small to moderate size tumor. It's quite a narrow surgical window, and the upper and the ipsilateral hypothalamic wall are sometimes difficult to expose. And I just want to finish to say that you have to be safe because sometimes you have a good surgery, good postoperative picture, but not that good postoperative outcome for patients with weight and neuropsychological issues. So the radical surgery, you have to think about that. Thank you.
Thank you for sharing us your very interesting talk on this Trans-lamina terminalis approach. It's not time to stay in France, but leave to Paris. And a great chance again to have with us Sébastien Fröhlich. We will discuss with us what to do in case of deep-seated craniopharyngioma retroinfundibular 1. Please, Sébastien, go ahead. Sébastien, you are muted.
You hear me? Yes?
Perfectly.
Perfect. Thank you very much, Michael, for the opportunity and organizing those webinars. It's very, very nice. So I will follow the steps of Emmanuel with, to me, the difficult case, the most difficult craniopharyngioma case, which are the one into the third ventricle or the infundibulotuberal types, where you have a significant relationship with the hypothalamus. And I completely agree with what Emmanuel said. What you want for those patients is not to break them with a devastating post-op complication. So I will go fast on the introduction, just saying that craniopharyngioma could be considered as a benign tumor, but the morbidity of the surgery is definitely significant and much, much higher than for other cellular tumor like pituitary adenoma. So it's benign, but it's for some cases, it's really a surgical challenge for the surgeon and for the patient. Two types, not so much signification with those, except that we now have medical treatment for those coming, and I hope it will be it will be another options in the future for those difficult cases. There is still questions about craniopharyngioma. Should we be aggressive or conservative? And I think most of us will discuss this, and we don't necessarily always agree on that. Choice of the approach, you will see in this webinar that there is many options. What is the role of radiation therapy? I think it's underestimated. Having a remnant of tumor, but a patient that is post-operatively intact is not bad, because radiation therapy is working for those tumors. What should we do for recurrence? When tumor recur after surgery, or even more after radiation therapy, it can become very, very difficult to treat those patients. And the outcome is not only a patient you can talk to in office during the post-operative control, it's also behavior, it's also weight, it's a lot of things related to the hypothalamus. So for those tumors, the challenge is really not to injure the hypothalamus. Hypothalamus is extremely important for many functions, and if you have a bad injury of the hypothalamus, it's absolutely terrible for the patient. Relationship with family, social network, everything is impaired, and really the patient is broken. So it's extremely important to keep this in mind. For most of those tumors, hypothalamus is the most important thing. I think surgical planning, MRI is extremely important. You can see here cases, depending on the sequences, you can have different, you can see different things here. With these Fiesta sequences, you can perfectly locate chiasma, mammillary body. You can see that the floor is going down. So it gives you a perfect image of where is the tumor on the relationship with the surrounding structure. In this image, you can see that there is edema of the hypothalamus, extremely dangerous case, and not worsening this patient post-op is a real challenge. Depending on the images, yes, you can see different things. You can see that some corridors are okay, some are not. In a case like this, for example, transcallosal, translamina terminalis is not a bad option, but going endoscopic, you see that the space between the chiasma and the pituitary gland is very narrow. It will be extremely difficult to get here. So carefully looking at the MRI before surgery for those infundibular craniopharyngioma, ventricular craniopharyngioma is extremely important to define the surgical strategy. Looking at the vessels also, I am not very familiar with Trans-lamina terminalis. Emmanuel is a master for this, but I have the feeling that vascular relationship also are important to consider. If you have space or not, if you can maybe sometimes cut the anterior communicating, but you have to be extremely careful with the perforators. All this can be anticipated looking at the MRI. So for me, goal of surgery is to decompress when there is optic deficit, decompress the optic apparatus, and to preserve the hypothalamic function, whatever it costs. So what it costs most often is a tumor remnant, but this tumor remnant, in my opinion, can be treated with fractionated radiation therapy quite efficiently. If you have hypothalamus dysfunction, it's usually for life if it's a bad one. This is data on radiation therapy. We have good evidence on the literature that radiation therapy is not a bad option for craniopharyngioma. It works. I advise you, like Emmanuel did it, to read this paper from Pasquale. It's a fantastic piece of information on craniopharyngioma classification, relationship with the hypothalamus. It's really, really great to understand this complex relationship with the hypothalamus. The worst cases in the classification are the infundibulotuberal, because of the relationship it has with the hypothalamus. Because it has a supial origin within the infundibulum, on tumor, yes, it has strong relationship with the hypothalamus, and there is no plan with the hypothalamus. There is usually pieces of tumor inside the hypothalamus, and there is no safe plane separating the tumor from the nucleus. So for those, you have to be extremely, extremely careful. This is coming from the same paper showing the adhesion pattern depending on the type of craniopharyngioma. Again, here infundibular type or ventricular type are the worst one because of this specific relationship with the hypothalamus. Position of the hypothalamus is important. When the hypothalamus is located at the inferior third of the lateral aspect of the tumor or the superior third of the lateral aspect of the tumor, it's okay. It's okay in term meaning that it's less risky than when the hypothalamus is around the mid part of the tumor. In this situation, it's definitely much more risky for the patient, usually associated with some hypothalamus edema. I am looking quite often to this mammillary body angle, which helps to locate the position of the floor of the third ventricle, which is an indication for the relationship with the hypothalamus again. Very important to look at all this. So there is many options for those tumors, infundibular, third ventricle tumors. Endoscopic endonasal approach, it's really a great approach that has been used more and more in the last 20 years. Definitely, it's my main approach for craniopharyngioma, but not only because I think for hormonal results, it's about the same. Style preservation, it's a dream. Because most often we preserve it anatomically, but at the end the patient doesn't have function. For vision, it's better, I think, because you're coming from below, but it's a suction traction technique. And whenever there is relationship with the hypothalamus, at least me, I'm not very comfortable with those tumors because you're sucking the tumor, and this can injure the hypothalamus. So sometimes I use other options for those tumors. And you need to know how to do those other approach because it can be extremely helpful. This was a case of a 42-year-old male, severe hypothalamic syndrome. He had intracranial hypertension. We put a shunt external ventricular drainage in emergency in this patient. And you see that the patient was so confused, so agitated that it was hard for us to have a good MRI because he was constantly moving. But still, you can see there is edema around the tumor. Fiesta sequence, difficult to get it because patient was moving, but still you can see that the floor is going down here. Direction of the floor is down. So it's quite intraventricular tumor, but definitely strong relationship with the hypothalamus. In this case, decided to do a transcallosal approach. The floor was below. I did a mistake in planning the entry point for the transcallosal. I was too anterior in this case. And you see that I had to leave this piece of tumor anteriorly because it was in a dark corner anteriorly, could not push forward the fornix. So what I did is I thought, how could I resect this piece of tumor? Trans-lamina terminalis, I'm not comfortable with it. Going endoscopic doesn't make sense because chiasma is too close from pituitary. So I went back to the same corridor, but with extending my craniotomy a little bit backward to have a better angle of vision for this anterior part of the tumor. I put also the endoscope inside to have an anterior look just in front of the fornix and immediately below it. Post-op was okay. He had a significant white gain after the surgery. Hypothalamic behavior symptoms improved. He had this little piece that regrow about a year after the surgery. Post-op MRI was quite clean, and we did radiation therapy, and I saw this patient Monday, and he's fine. It's now 5-6 years from radiation, and he's okay. This was another case, 35 years old, similar than before, very severe hypothalamic syndrome. But in addition to what the other guy had, he had severe visual, decreased visual acuity, panhypopituitarism, intracranial hypertension syndrome also. So in this case, because you see that it's closer from the pituitary gland, I thought it's very cystic. I thought endoscopic endonasal approach would be nice. And this is what I did. Here is a video of it. Here is a video of it. I don't know what this voice is coming from. I think it's one of my fellow Mujahid that is commenting. And yes, so endoscopic approach, classic technique, nothing special with this. What I want to show you is how it looks inside. I go fast on this. When you start here, you feel, is it a good option? Because you don't see much of the tumor, but if you stay calm and keep going, it's getting better. Here you see the stalk with the tumor above it. Progressively, I'm trying to make a hole inside this tumor. Don't necessarily want to cut the stalk up front. I'm getting inside the tumor, sucking everything I can, using the CUSA because it's a little bit strong. And then I am into this cyst. And into this cyst, I don't know exactly what to do. I don't feel comfortable peeling the wall of this cyst from the wall of the third ventricle. This is the inside of the cyst. And definitely, you can see transparent the hypothalamus and the wall of the third ventricle behind. And personally, I didn't want it to peel this cyst from the wall. It was not coming. It was not a cyst that was coming out from the wall of the third ventricle. It was adherent. So I decided to stop here. Post-op was quite disappointing. The cyst was much smaller, but extremely rapidly it came back. At least it was even worse, in fact, going a little bit more upper. He came back in emergency also. And one of my colleagues did an endoscopic approach to empty the cyst, and it was better. And also the same, rapidly the cyst grow again. And what I did for this, at this stage, decided to do a posterior petrosal approach. Posterior petrosal approach is, in my opinion, a very nice option for those tumors because you're looking at the floor of the third ventricle from below, from behind, and you are behind the stalk. So it's really an upward line of sight, looking down up to the area where those retroinfundibular craniopharyngioma are. So it's a little bit painful. Definitely, it's longer than doing, like Marcos showed it, a classic lateral supraorbital approach. But the line of sight is very interesting. And the distance is quite short because of the transposition of sigmoid and transverse sinus. Here is a section of the tent. And once you have cut the tent, you have the fourth nerve and you are looking at the tumor from below. The thing that is between you and the tumor is the third nerve a little bit below, the posterior communicating artery above it, and some perforators of the anterior of the PCOM. And this is a tricky part. You have to be careful with those tiny vessels, but you are getting into the tumor from the good plane, good entry point. So here is opening of the cyst. And you can really, because the distance is not so long, you can really peel this layer from the tumor. And I was able to peel the tumor from the wall of the hypothalamus. Patient was quite severely impacted already. So the goal here was to try to save this patient because tumor was coming back extremely rapidly. So this is not necessarily something I like to do, but yes, here I tried to remove the wall of the cyst from the hypothalamus because I thought that the hypothalamus was already quite severely injured because of the symptoms of the patient. But you can see here the peeling of the wall from the wall of the cyst. I was able to achieve a quite nice resection. Stalk was preserved anatomically, but didn't make much difference because he was already pan-hypo before the surgery. And this is looking with the endoscope. You can see the third ventricle from below. And this is really the nice view, the nice advantage of this technique. You're looking at the third ventricle from below. Quite similarly than from the transphenoidal approach, except that you are coming from behind the infundibula. Post-operative course of this patient was fine. There was a tiny piece of tumor at the level of the tuber, but not so much. He improved vision significantly. Hypothalamic syndrome also over months, but he had significant weight gains, about 15 kilos at the end. Do I have still a few minutes or not? Michael?
Sorry, I was muted. Yes, a few minutes.
Okay, I just finished with this case. It's another similar case, much smaller tumor, definitely, but it's a retroinfundibular tumor. Infundibular, retroinfundibular tumor, in fact, going into the third ventricle. This patient was only symptomatic on visual field. Pituitary function was normal, and she had a slight weight gain in the last year. Difficult to say if it was because of the tumor or not. So here I was not comfortable with endoscopic endonasal because this is sacrifice of the stalk, and in this patient I wanted to try to keep pituitary function. Posterior petrosal is very nice for that because you have a very nice view of the stalk, short distance. You can use a 2-pincette technique to dissect the stalk, and this is what I did. Yes, it's a significant approach, I agree, but if you know how to manage it, it's normal anatomy. It's not so long, it's about 2 hours, I would say. Mastoidectomy is not something difficult. ENT residents learn it quite soon in their training. In fact, the bone flap is more painful than the mastoidectomy itself because you have to do it over the transverse sinus, keeping the sinus intact. But other than this, it's really normal bone anatomy, normal bone drilling. So here is the craniotomy. We did a cosmetic mastoidectomy as we do most often. This is a mastoidectomy keeping the labyrinth intact. So you drill the petrous ridge. In fact, you focus behind the labyrinth along the petrous ridge. Here we take the bone over sigmoid sinus because the goal of this approach is not to work through the retrolabyrinthine corridor, but to transpose the sinus behind to have enough space. It's like opening the Sylvian fissure. Here we open the fissure between temporal lobe and cerebellum. So same than before, we cut the tentorium. We sacrifice superior pectoral sinus as anterior as possible. Here is a section of the tent. And here is a dissection of the fourth nerve. Fourth nerve is a nerve at risk. In fact, you have to be extremely careful. Here is the third nerve, and we're going to work above and below the third nerve. You can see the tumor. Nice view of the tumor from behind. I am doing here a little hole to empty the cyst, and progressively I remove the tumor behind the infundibulum, and pretty soon you can start to see the stalk. And you see that I am working into the stalk, but from above, from above the stalk. if you come from below, there is no way to keep the stalk intact and to keep the vascularization of the stalk. Here I was able to keep those tiny vessels because I did not use coagulation. So I did a quite nice resection, leaving a very small piece of tumor at the level of the tuber. But at the end, she had a normal pituitary function post-op. She had a slight DI, but she recovered rapidly. She had a recurrence about 2 years after, small recurrence, and we treated her with radiation therapy, and it's now 3-4 years. She's intact. You can see that the stalk is quite nicely preserved. I don't think you can achieve this with an endoscopic endonasal approach. Okay, I think I'm done. Thank you very much.
Thank you so much, Sébastien. Very impressive. You detail us, so it's important to master all the access and to adapt the technique, the location and extension of the craniopharyngioma. Thank you. Then we will listen to Luigi Cavallo, who will discuss with us transphenoidal approaches. Luigi is not able to join us online, but so its commitment is so important that it was kind enough to record his presentation. I know it takes more time when you have to record a presentation, but he made it. Its commitment and implication for the skill-based section is impressive. And I would like to thank again all our colleagues from Naples for their involvement and their participation to our skill-based activities. Thank you so much. So I will start to share my screen with the Luigi's talk. Please.
Hello to everybody. Good afternoon. Unfortunately, this time is not possible for me to be present this webinar. Anyway, I will try to do my best in presenting the experience of our group in Naples on the endonasal management of craniopharyngioma with the intraventricular extension. Traditionally, two kinds of approach have been used to manage craniopharyngioma: transcranial through different surgical corridor and transphenoidal. Transphenoidal route has been used mainly for infradiaphragmatic craniopharyngioma, which are those craniopharyngioma in which the subarachnoid space is not involved, and are tumors that grow below the level of diaphragma cell. This tumor really appears like most of the time are cystic tumor, and if we follow this patient over the time, they have for sure a better prognosis, because even if they can regrow, they regrow almost always below the diaphragma cell. So this means that they regrow inside the cell, and redo surgery is quite easy in these cases. Of course, completely different is the situation for supradiaphragmatic craniopharyngiomas, because this kind of tumor were traditionally approached transcranially. Over the last 15 years, the endonasal route has been reconsidered not only for infradiaphragmatic craniopharyngioma, but also for larger supradiaphragmatic craniopharyngioma, thanks to the so-called extended endoscopy.
It seems like we lost sound.
Yes, but I don't know why. The recording is running.
microscopic transphenoidal approach.
Okay, it's back.
Supradiaphragmatic craniopharyngioma. But for sure, it has been thanks to the endoscopic approach that was possible to push the limit of the endonasal technique for this pathology. When you have to manage such disease through the endonasal route, you have to be a little bit more invasive as compared to the approach you do usually for pituitary adenoma. I mean, you have to resect one middle turbinate, you have to resect a little bit more the posterior part of the nasal septum. This because you have to reproduce the macrosurgical attitude through the nose. You have to work bimanually, and you need somebody who hold the endoscope and move dynamically inside the nasal cavity. Also, some dedicated instruments are required for this kind of approach. This is the craniectomy that we can realize over the planum, and this craniectomy can be tailored according to the extension of the realize the craniectomy over the planum sphenoidale. These are the corridors that we can explore. We can work below the chiasma, above the chiasma in the retrocellular space, but even inside the third ventricular chamber. Once you have opened the dura, you see nicely the chiasm. You can dissect the tumor from the pituitary stalk below the chiasma, and then you can work also behind the chiasm into the retrocellular space. You can widely open the arachnoid here, and you can also recognize nicely the limit of the tumor with the floor of the third ventricle. You see, so you can do all the surgical maneuvers under direct control. You can use also CUSA. Some cases you can even work above the chiasm through lamina terminalis. Here you can see the limits of the tumor with the third ventricular wall. And this is our series made mainly by the Transcranial procedure. Series which include also some pediatric patients. So different kind of craniopharyngioma can be managed through the endoscopic and nasal route. Of course, not only infradiaphragmatic. With good results in terms of gross total resection, and above all, very good results on visual function. And since the beginning, we noticed that also craniopharyngioma growing through the infundibular recess of the third ventricle, or even those growing male inside the third ventricular chamber, had really good postoperative results with good gross total resection rate. As you can see in this schematic drawing, if in normal condition, of course, the floor of the third ventricle is far from the cella, when we have some disease like craniopharyngioma growing inside the infundibular recess and then extending inside the third ventricular chamber, they push down the floor of the third ventricle so that the tumor itself creates a sort of corridor to enter from the supracellular space inside the third ventricular chamber. Through an anatomic study, we have described 4 areas inside the third ventricular chamber, and 3 of them explored with the first one is the infundibular one. The first one is the infundibular one. When you enter the third ventricular chamber from below, it's very important to early recognize now some cases of craniopharyngiomas with the intraventricular extension. In this picture, you can see how can appear the anatomy of the third ventricular cavity after tumor removal. And you see that sometimes the anatomy can be distorted by the tumor, but it's always very important to check the anatomy of the floor of the third ventricle. The tumor. In this video, you can see the case of very rarely they are purely inside the third ventricle, while in the vast majority of the cases are growing from the dibulum to the cap. In coronal, as you can see, almost all are pure in the line. In and coronal plate. Now these are the cystic intraventricular craniopharyngioma, despite their appearance. Case of young boy, transphenoidally, with good post-operative clinical and radiologic. Slides. This is another case. Very cystic tumor to widely communicate muscle sister, cyst wall, in of cyst remnant to do as soon as possible radio, which seems to be quite effective on cyst wall. Can be therapy, positioning of Ommaya reservoir. So in order to avoid the scars of the previous surgery, you can simply change the route to use an opposite way to reach the tumor. When you change the route, what happens is that you can avoid the scars of the previous surgery. In this case, where the prefixed chias, you see we're removing the solid part of the tumor. Then we remove the catheter, which was positioned previously. And then we can explore the ventricular cavity, you see, and check along the floor of the third ventricle. And then at the end, we can dissect this solid part of the tumor along the floor of the ventricle. And then after the removal of this piece of tumor, we can check inside the ventricular cavity and you see the prominence of mammillary body intact. This is the pre and post MRI of the previous case. But of course, we have not only to consider the endonasal route to manage craniopharyngioma. This means that there are cases in which instead of using the endonasal route, we have to consider other surgical routes. Another surgical option that we can consider is the endoscopic transventricular approach, which we can use especially in recurrent tumors growing inside the third ventricular chamber, as we reported thanks to Emmanuel Jeannot in this paper. Particular with the recurrent cysts, and most of the times problems comes from cyst recurrences, so that you can use the different transcranial approach to manage such kind of recurrent tumor. Last but not least, I would like to conclude this presentation with the skull-base reconstruction, which really represent a sort of Achilles heel of this technique, especially in the past. And what we are now proposing is the 3F technique. Very easy, very fast, and it's made just by a piece of fat which is positioned across the entire skull base defect, not inside the spinal sinus, but just across the skull base defect. Then the fat is covered by flap, nociceptal flap, and then the third F is for flash mobilization of the patient from the bed, so that they don't need to stay anymore in the bed, no need of lumbar drainage, quick mobilization, and with this technique, we dramatically reduce the rate of post-op CSF leak. And with the hope to have soon better weather and no COVID anymore, I thank you so much for your attention. Bye-bye.
Thank you so much to Luigi and Naples colleague to have shared with us their impressive series of patients treated for craniopharyngiomas. Sorry for the recording, maybe in relation also with the fact that I'm working with the Mac. So thank you so much to Luigi and Paolo Capabianca for sharing your experience. It's now time to move to the next speaker, who is Professor Messerer from Lausanne. Please, Mahmoud. You are maybe still mute.
Okay, thank you. Thank you very much, Michael. I'm very glad to be here with you. You can see my screen?
Yes, very well.
Yes.
So I will talk about transphenoidal approach, indications and limits. In the literature, there are many classifications based on different anatomical structure, the diaphragm cilia, the optic chiasm, the infundibulum, the third ventricle. This is one of the first classification of craniopharyngioma, published 30 years ago by Yazargil, based on the location if the craniopharyngioma is purely intracellular or if there is a supracellular extension of if the craniopharyngioma is purely intraventricular. Another classification by Kassam's team based on the situation and the relationship between the tumor and the infundibulum. For type 1, it's classified pre-infundibular, type 2 transinfundibular, and type 3 between the pituitary gland and the stalk. For the type 4, the craniopharyngioma is located purely intraventricular. Another important classification is Necker's classification based on the invasion of the hypothalamus. For type 0, there is no involvement. For 1, the hypothalamus is just displaced, and for type 2, the hypothalamus is invaded. It's very important because we can predict the post-operative prognosis, and especially if we can plan the subtotal resection if there is an invasion of the hypothalamus and to avoid post-operative hypothalamic syndrome. But I think there is no comprehensive complication combined all these factors. All surgeons have to planify his surgery before and analyze carefully the images before the surgery, the relationship between the tumor and the diaphragm cilia, if there is a supracellular extension, the relationship with the infundibulum, the location of the optic chiasm, if there is a small part of the tumor inside the third ventricle or all the tumor inside the third ventricle. An important point also the invasion of the hypothalamus, and also if there is a lateral extension, especially lateral to the internal carotid artery or if there is a part of the tumor in the temporal fossa. Every surgeon do this kind of surgery knows there is a high rate of complication. In this retrospective study, we can see 20% of visual deterioration and more than 80% of hormonal deficit, hypothalamic dysfunction, and 15% of CCF leakage, especially after endoscopic endonasal surgery. That's why you have to choose the right treatment with the right strategy to avoid this kind of complication. Last year, we created the task force with the ENS skull-based section with some other international experts. We did a systematic review to try to answer some questions, and we based it essentially for surgical management. I cannot detail this paper, but I will focus on two important points: the indication of endoscopic endonasal approach in craniopharyngioma, and the second point, should you do gross total resection or subtotal resection followed by stereotactic radiosurgery? There are two cases of classical craniopharyngioma. In the first case, we can see here the solid part, and important cyst part goes lateral to the internal carotid artery in the temporal fossa. I think for this first case, transcranial approach is an excellent indication, and a cyst, you can use the cyst as your surgical corridor to access to your solid part. For the second case, it is a big craniopharyngioma extended posteriorly to the peduncular space. And we can see the craniopharyngioma doesn't cross the internal carotid artery. I think it's a very good indication for extended endoscopic endonasal approach. So we recommend to use the traditional endoscopic approach for poorly intracellular craniopharyngioma. Unfortunately, poorly intracellular craniopharyngioma is very rare, but it's an excellent indication like pituitary adenoma or poorly intracellular lesion. And now we agree that transphenoidal approach for purely intracellular lesion is the gold standard approach. If the craniopharyngioma extend in the supracellular space, you have to study carefully the location of your craniopharyngioma. If the craniopharyngioma is still in the midline without crossing the internal carotid artery, I think extended endoscopic approach is a good option. When you do an extended approach, it's very important to repair your skull base. And like Luigi said, it's very simple now. You have to put just fat, your nasoseptal flap, to repair your skull base. You don't need the multi-layer and exogen material. This is a small video of extended endonasal approach for craniopharyngioma. This is a simple diagram of nasoseptal flap. We decide to draw 4 lines. The first one just below the nasoseptal artery, and the last one just below the sphenoid osteum. When you do your flap, you put your flap in the guana to protect it during your surgery. This is a surgical view, and you can repair also your nasoseptal artery by a Doppler. This is the second line. After that, we do the third line, and finally, the last one just below the osteum. It's very important to protect your flap during the surgery. After that, you have to expose widely the anterior wall of the sphenoid sinus, and you see both ostea. After that, after you opening your sphenoid sinus, you have to see all the important anatomic landmarks. In the midline, you have to see the planum, the tuberculum, the cellular floor, and laterally both optic nerve, the prominence of the optic nerve, the internal carotid artery, medial optical carotid recess, and the lateral optical carotid recess. It's very important to see all these important anatomical landmarks. After that, you planify your craniotomy. It depends on the size of your tumor. And laterally, it's very important to go to the medial optical carotid recess to see the emergency of your both optic nerve. Without that, you can injure your optic nerve. After that, you open your dura. It's classic. You start with a micro dissection, and after that, it's very important also to see all important vascular and nerves. Donc, here you can see the right optic nerve, the left optic nerve. This is your tumor, the chiasma, the anterior communicating artery, and A2. Before that, you cannot start your dissection. It's very important to see all your vascular element, and after you can do your classical dissection. It's a piecemeal resection. This is the superior epiphyseal artery. It's very important to keep it intact because it vascularizes the optic nerve and the chiasma. After you remove your tumor, you do your skull base reconstruction with the fat and your nasoseptal flap. This is the post-operative MRI. You can see here the enhancement of your flap and the gross total resection. I want also to share with you this video. I took it from a WhatsApp group, international WhatsApp group, and I want to show you what you shouldn't do. This is you can see here. This is a very small craniotomy. You cannot see the optic nerve. You cannot see the prominence of the carotid, and the surgeon is just pulling the tumor. It's very dangerous concerning the perforating arteries, the optic nerve, and the hypothalamus. It's a very, very bad technique. Concerning extent of resection, I completely agree with Emmanuel and Sébastien. If you can do gross total resection, okay, you can do it, and you can cure your patient. But if there is risk, even if the risk is small, to injure your hypothalamus, go to the subtotal resection followed by stereotactic radiosurgery. And all the literature support now this management. There is no difference between gross total resection and subtotal resection followed by stereotactic radiosurgery in progression-free survival, and especially also in the all when you do gross total resection and injure your hypothalamus, the consequence and the quality of life of your patient is very poor. This is a good example of combined management between extended endoscopic endonasal approach and gamma knife. This patient was operated by endoscopic endonasal approach. At D1, the MRI showed the gross total resection. At 3 months, we can see here a small cyst in the right hypothalamus, but we weren't not sure if it was a scare or a recurrence. 2 months later, we repeat the MRI and the cyst increased. We decided to treat it by gamma knife, and 5 months later, the cyst decreased, and at the follow-up 3 years post GK, there is no residue. It's a good example to combine different techniques. So to conclude, there is no level 1 or level 2 evidence supporting the choice between the transcranial approach or endoscopic approach. But now we can assume that there is some evidence for indication for endoscopic approach. If the lesion is poorly intracellular, endoscopic endonasal approach is an excellent indication. And if the lesion stills in the midline without crossing, and especially in retrochiasmatic space, also endoscopic is an excellent alternative. For resection, for the extension of the resection, if you can do gross total resection, yes, you can do it, you have to do it, but don't damage your hypothalamus. For young neurosurgeon, I want to say there is no competition between the endoscope, the microscope, or radiosurgery. You have to use all this armamentarium to do your best for your patients. Thank you.
Thank you so much, Mahmoud, for sharing with us your experience and to stress the importance of combining the techniques and working with our colleagues of radiation therapy and gamma knife to treat the patient efficiently. And say hello to Marc Levivier, a friend from Lausanne from me. Happy to see him. Maybe if you can stop to share your screen. I will give you the opportunity to Henri Schröder from Westphal to start. And Henri, tell us, are you sacrificing the stork or not?
That is my secret. I'll let you know. At first, I want to thank you again for the invitation to this nice webinar series. That's really a great initiative. And I think most facts have already been mentioned by the previous speakers, so I can make it easy. I think, in my opinion, the endoscopic endonasal approach has a big advantage, and that is that you can very early identify the stalk. And that is better than compared to the microsurgical approaches. So you know very easily from the beginning, where's the stalk? Is it infiltrated or is it just displaced? And that is the main advantage for me regarding the stalk preservation. And if you look to the literature, there are different opinions. Some people, they say that even if you preserve the stalk, it does not mean that it's working. And I have the same experience. Sometimes you can preserve the stalk anatomically, but it's not working. And then you have only the risk that there is some tumor tissue in the stalk, which causes later on recurrence. And there is the opinion of Oldfield. He said, if the remnant at the stalk is the only piece of tumor which may cause a recurrence after resection, then he would advise for stalk, because in the Western countries, you can easily substitute the hormones. But if you have a child in some other countries, so I have been in Bangladesh and we made a surgery for a craniopharyngioma, and I said we could remove the tumor totally, but we have to sacrifice the stalk and he needs substitution. And they said, no, please don't do it. He will die because he cannot afford the medication. So you have to consider all these factors also when we make the decision of how radical our surgery is. And there's an interesting Japanese paper. They say even if they make an aggressive surgery with resection of the floor of a third ventricle and sacrifice of the stalk, they have a preservation of stalk function in some of these patients. So 50% have no DI, although they cut the stalk. Unfortunately, I could not have these results in Germany. The German patient seems to be more susceptible to stalk sacrifice. If I cut the stalk, they always have DI. There's a nice classification of craniopharyngiomas according to location in regards to the stalk. There's the pre-infundibular type in front of the stalk, the transinfundibular type where the tumor is within the stalk, and the retroinfundibular type where the tumor is behind the stalk. And this is quite nice when you do endoscopic endonasal surgery. So in the pre-infundibular type, if you open the dura, you see the gland here, optic nerve here, and you just see the tumor. So you don't know exactly where's the stalk. But on the other hand, these tumors are the best in regards of total resection with preservation of the stalk. So this was a guy with visual problems on the right optic nerve. He was endocrinologically intact. And if you look at the MRI, you see a cystic lesion, but it's very difficult to say where is the stalk, in which direction is it displaced, is it left or right? But we make an endoscopic endonasal approach because you see this is a gland, this is the optic nerve, there's much space to go in. And this is a exposure, so we open always the bone or the cellus floor, and then we open the transtuberculum approach. This is the arachnoid, we open it. Here's the gland, and you just, if you cut the diaphragm and follow it, you will find the stalk. You see the stalk is pushed here in the back, and then we dissect. If you see the stalk so nicely, we make a sharp and blunt dissection with preservation all of these small vessels from the superior hypophyseal artery. I think it's very important that we always preserve these vessels to have a good visual outcome. You see the sharp dissection along the infundibulum, and here's some adhesions to the optic chiasm. Also, we open the arachnoid, and then we have a bimanual dissection with traction and counter traction. You see this is a stalk, this is a tumor. We have a very nice plane. Here you see this are some vessels. These vessels are not supplying the tumor, but they supply the optic chiasm. So we try to preserve all of these small vessels to have a good visual outcome. And another advantage is, of course, we do not need to manipulate the optic chiasm, as you have seen in the series of Marcos Tadajiba when he makes the Trans-lamina terminalis approach. And then only if the tumor is completely dissected, we will remove it. The previous speaker pointed out that pulling is a very bad option. And this is a post-op result. You see it looks very good. Stalk preservation, no gain of weight. And he also needs no substitution. So this is the ideal case. The pre-infundibular type is a very nice tumor for stalk preservation. With the intrainfundibular or transinfundibular type, it's different. If you open up, you see this is a stalk, and inside all is tumor, and all the layer around is a stalk. It's paper thin. And if you resect all these tumor, you have to sacrifice the stalk. So we open it on the side. If the patient has a good function, we evacuate it. And you see this is a view again to the stalk. If you take these all out, this is all infundibulum. Then of course you will have a deficit. This was a young guy. He was sent by his girlfriend because she was not happy with his performance, and the endocrinological investigation revealed a partial pituitary insufficiency, and MRI shows a huge lesion extending into the third ventricle. And if you look to the sagittal view, you see the huge tumor filling all the third ventricle. What is the best approach? Many people say transcallosal, but I think we should come in the longitudinal axis of the tumor. And then it's very important that we look. Here you see the gland. This is the chiasm. So we have a large space of almost 1 centimeter between chiasm and the pituitary gland. And that's why I think it was a good option to make an endoscopic endonasal approach in this tumor. If this is very narrow, of course, you will have a problem, and a transcallosal approach is a better option. So we have to look very careful at the images. So the dura is already open. You see this is a gland, carotid, optic nerve left, optic nerve right. Here's the arachnoid. So we open the arachnoid and you see the whole, this is all stalks. This is not tumors. This superficial layer is a stalk. So we open the stalk and then we dissect. It's very important to find the right plane between the tumor and the stalk. Ultrasonic aspiration, as already mentioned by Luigi, is very nice to debulk it. And what you see here, this is no tumor capsule, this is all stalk. And you see the tumor is sticky to the third ventricle. And that's why bimanual dissection is very important. We grasp the tumor and in this gliotic plane, I dissect. If this would be a white tissue of the hypothalamus, I would immediately stop. But you see this is a gliotic plane around the tumor. And with traction and counter traction, I dissect the tumor away from the hypothalamus. And I could not reach it. It was a 45-degree endoscope looking up. I could not reach this area. I had to bend my suction, and then I can go around the tumor. You see the fornix coming here. This is the roof of the third ventricle. And only after complete dissection of the tumor, then you should remove it. No pulling before. But here now, the tumor is taken. And this is a view to the roof of the third ventricle. You see here posterior commissure, fornices. There's a big hole. Of course, we need fat and a flap, and we also place a lumbar drain if we have such a high flow leak. So after 10 days, shows a gross total resection. And this is after 4 years. And I think now it's after 8 years. He has no recurrence so far. There is stalk preservation, but it's not working. So he needs full substitution. But with this full substitution, his girlfriend is happy with him again. This is another case. This is a 76-year-old female, visual problems, but endocrinologically completely intact. You see this cystic lesion here. So we went in, we see the cystic lesion, we open it, decompress the chiasm, and then we look to the stalk. This is all infiltrated stalk. So does it make sense to remove the stalk now in this such a lady? I don't think so. So we make the decompression, the optic nerve is free, and then we send her for fractionated stereotactic radiotherapy, 54 gray. And this is now almost 3 years after surgery. The tumor is gone, you can't see it. And so far, she does not need hormonal replacement. Of course, the ideal treatment is total resection with preservation of stalk and no radiation, because some of these patients get after radiation a pituitary insufficiency. Another lady, 84 years old, visual problems, but again, endocrinological completely intact. What we do, we go in, we dissect the tumor, but here you see this is all stalk, completely infiltrated. So I left it, and this is a remnant, what we see after 3 months. And then again, we sent it for radiation, and you see the tumor shrinking down. So the radiation is really a good option in adult patients to avoid DI in these old patients. I think this is a better option for these. And if you look at the literature, there's clear evidence, as you have seen from previous speakers, that the radiation, even in the long term, after 20 years, we have a control rate of 88%. So it's really a worthwhile option to consider. The last type is the retroinfundibular tumor. You see, we open it, you see the stalk and tend to go behind. So I do not agree with Sebastian, although he has very good ideas to resect. In these cases, I always would try at least to make an endoscopic endonasal approach. You see again, it's a retroinfundibular tumor. So we open the dura. You see, this is stalk, this is a chiasm. And here behind the stalk, there is a tumor. So again, we dissect with bimanual dissection, traction, counter traction, sharp dissection, try to preserve all the small branches of the superior hypophyseal artery to have a good visual outcome. And then we find the plane between the tumor and the hypothalamus. Careful dissection. It's always important that you really keep the right plane, sometimes difficult. And if you see there is an infiltration in the hypothalamus, of course, we have to stop. But if you find a plane, can be a gliotic plane, we can continue with the dissection. And then sharp dissection of last adhesions. And only after you have really completely dissect the tumor from the surrounding structures, you take it out. You see stalk preservation, and here is the area where the tumor was adherent. Improvement of vision. This patient had DI after surgery for some weeks. He did not gain weight, the same as he came in before. And after 6 weeks, he needs some replacement of hydrocortisone and pyroxene, but otherwise he's doing fine. And we investigated our series, and we see stalk preservation and gross total resection in the endonasal approach is possible, but the transcranial approach was much more difficult. So I think the chance of preservation of the stalk in the endonasal approach, even if you have a gross total resection, is better. So our philosophy in these tumors is, if the patient presents with pituitary insufficiency and DI, we sacrifice the stalk. This is no question. But if the patient is endocrinologically intact and the tumor can be dissected, as I showed in the pre-infundibular types, then of course we do a gross total resection. But if I see that it's an intra-infundibular type and the chance of preservation of the stalk is very low, I think it's a very good option that we make a subtotal resection and we add stereotactic radiotherapy. And my conclusion is that the gross total resection is of course the best option because you can avoid radiation, which might lead to later on pituitary insufficiency. But if you see that we lose the function of the stalk for sure, then I think the radiation is a better option. It's no question, if you have the hypothalamic infiltration, then you have to stop. This is no question, it's just regarding the stalk. So thank you for your attention.
Thank you so much, Henry, for this impressive talk and impressive video you showed us. Thank you, it's very incredible. So it's time to move again to Emmanuel Joanneau. If you would like to speak with us about your European network, about craniopharyngioma, please. It will surely interest most of us. Emmanuel?
Yes. Don't see the presentation?
Not yet.
have some trouble.
If you want, I can discuss a case in the meantime, and you will finish with your. We can finish with your talk. Okay, it's in order.
Is that good?
Perfect.
Okay. So I will be very fast because it's the beginning of our idea on our project. The beginning was with the work that Mahmoud Messerer showed you previously. He reviewed and he was doing a nice work, but it's always retrospective data. And when we look at the literature, it's always difficult, especially on, for adult craniopharyngioma. It's very difficult to be comparable between series, and the series are very small. So we think about European work on focus on adult craniopharyngioma. Doesn't work. So I just remind you the first sentence of Hervé Cushing about craniopharyngioma. Craniopharyngioma are the most formidable of intracranial tumor. It's still true. I mean, it's always, there is many progress, but it's still true. It's always difficult and challenging tumor. There is a long journey from the first description of a dame who described histologically the first craniopharyngioma, and then a tumor. And after, there was everybody know the work and the famous job of Hervé Cushing, perhaps less Norman Dott, who was the pupil of Hervé Cushing and who was the first to really understand the relationship between the clinics and the adiposogenital syndrome and the invasion of the hypothalamus, because he was doing surgery in two-step and surgery through a transventricular corridor. After, in France, we start again to operate endonasally with starting from Glio. Hardy was doing with this kind of surgery with microscope. It was a famous pituitary surgeon. And after, there is a very famous other neurosurgeon who's promote the shifting from the microscope to the endoscope. Here at Lowe's, Paolo Capabianca, which was one of my master for endoscopy, the Pittsburgh group. So a long journey from the first description. And now we are moving to molecular era. You all know that for papillary craniopharyngioma, there is a BRAF mutations on target therapy. It will become very close in the future in adamantomatous tumor with a CTNN B1 mutation and the beta-catenin mutations. So there is many data, but there is still many questions, and especially in adults, because adults, there is one question in the chat that mentioned that adults are not all children, and it's not the same tumor. And there is a lot of pediatric tumor. We gain experience from the pediatric neurosurgeon and pediatric tumor, but for adults, it's not the same problem, the same issue, and the same goals. So when we look at the literature, the pure adult series is quite rare, and there is many questions and many progress to do because it's very difficult to be comparable between series. And there is many question about epidemiology, hypothalamic dysfunction, preoperative hypothalamic dysfunction, quality of life, many questions, and unresolved questions about surgery, about radiotherapy failure, about the management of cystic craniopharyngioma. We were lucky to work with Paolo Capabianca teams, And just to show that when you have a pure ventricular cystic craniopharyngioma, you can treat only with catheter on to open up the cyst inside the third ventricle, and in more than 70% of cases, you can follow the patient without doing anything else for years, and the person is doing well because we don't worsen the patients. And also there is many questions about on how to manage the recurrence, especially with the time of the molecular targets. So now we know that target therapy work, at least for papillary craniopharyngioma, but there is only case reports. Here is one example. I operated 2 years ago. It was considered, endonasally, it was considered as a radical surgery. 1 year after the surgery, there is a recurrence of the tumor, very sticky to the chiasma. The patient was worsening, was with a visual worsening. I decided not to treat again. It was a papillary craniopharyngioma, not to treat again with surgery because it was too sticky to the chiasma. Here is the result after only 2 months of the target therapy, 2 drugs. We use 2 drugs, and here is the result after 4 months. So it works, but there is many questions about target therapy. How we can use it, how long it will work, in which situations we have to decide. So many questions. So the idea, and we decide to work around a multicentric protocol. We will propose in a lot of center, European center, because it's quite rare tumor, and if we want to have prospective data in large cohorts, to be comparable and to have strong conclusions, we need to have a multicentric work. So we are working about a multicentric protocol to design a common record we can propose to every center that will be interesting to be involved in, about preoperative assessments, about endocrine, ophthalmologic, imaging, hypothalamic, about after surgery, histological information for checkup, for postoperative follow-up. And the second questions we can walk around, it's about to collect recurrent patients, especially target therapy treated patients, trying to answer a lot of questions. Can we use, like in my case, target therapy before radiotherapy to reduce the target, to decompress, and after have a more small target to the therapy? Can we use after radiotherapy? How long it works, the side effects? So there is many questions. And the idea is to do the same, exactly the same European task force that the endocrinologist did for aggressive and atypical pituitary adenoma. And it's the idea we have. And so we are actively working on the protocol, design a protocol and common record we can propose to center interesting to be involved in that work. We have already some centers that are interesting to work with, to work with us, Lausanne, Italy, Belgium, France. I hope Paris will be interesting to be work on that. Marseille for sure. There is other colleagues we can ask. Elam Rostami work a lot on the target therapy. Ruth Prieto should be probably a good candidate, and so on and so on. So it was just the beginning. It's just an information about what we are doing, what we are trying to promote, because I think it's also one of the goal of the school-based sessions, not only to to promote educational course, but also to promote research and multicentric works. So feel free to contact me, and I will get back soon with the design protocol, and we will ask for more colleagues in each country. Thank you.
Thank you so much, Emmanuel. As you said, it's very important to collect such data prospectively in order to better improve the management of such patients. And for rare diseases as craniopharyngioma, it's very important. Can you stop to share screen?
Yes, I try.
Perfect. So I hope your initiative will be followed by many people, and of course, you will have my support in my department in UZ Brussels, surely. And do not hesitate to give more information in the future on how to proceed in order to participate. I think we have had again a great webinar. I prepared a case if we have still time, and I would like to share nevertheless with you another way to treat and approach craniopharyngiomas. And because none of you are focused on this approach, I would like to show this case. So I will share my screen, just 2 seconds. So can you see my screen?
Yes.
Perfect. It's always the case of we are facing sometimes such patients with recurrent craniopharyngiomas, and those patients are very difficult to manage. This is the history of a patient who was 38 years old in 2011, and the patient present initially with ophthalmological disturbances with bitemporal hemianopsia. A neurological examination was normal, no endocrine dysfunction. At that time, the surgeon made a chiasmal decompression through a right-sided cranial approach. Then the patient was treated with fractionated radiotherapy. Hormonal status remained normal. The patient recovered in terms of ophthalmological function after this management. What happens in 2015, the patient presents again a worsening of her vision. Then hormonal status starts slightly to be impacted with an increase in the prolactin. The patient was then reoperated on partial resection to decompress the optic chiasm. There are adhesions of the tumor to the hypothalamus and pituitary stalk, and postoperatively the patient show a panhypopituitarism. This is the postoperative images. What happens? The tumor still progress, and this is the situation in 2019, with again worsening of the vision, but now the patient start with neuropsychological disorder, with memory loss and endocrinological dysfunction induced at least fatigue. This is the MRI before the third surgery. You see now the remnant is growing, become more and more difficult to attack. The patient underwent a third resection. Partial resection, again, the compression of the optic chiasm, and again, it is the craniopharyngioma, adamantinomatous type with CTNNB1 mutation, or again, a grade 1 tumor, but the tumor is progressively deteriorating the patient. What happens? This is the situation now. When the patients come to me, we are at the end of 2020, and you can see how big is now the tumor, extending from the sella to the ventricle, the third ventricle, compressing the hypothalamus. The patient worsens in terms of vision, in terms of cognition. So This is the axial slide. You can see the involvement of many structures. You can see the involvement of all vessels. I will just take a look to show you after why. I'll take a look on the A1 segment. We were of similar size. So what are your management of this patient? I will just stop maybe to share my screen for a few seconds and give the possibility to the speakers to give me what's your opinion. How do you attack this tumor? What do you think? What do you propose?
First, this is a very strange course. I have never seen a patient which had got radiation in my place. So really stereotactic fractionated radiosurgery recurrent. We had some cyst formations where we opened the cyst and sent for histology, and they said, no, there's no tumor inside, it's just a cyst formation. But this is a very strange case. So this is very rapidly growing. So this, for me, looks like a progression to a malignant tumor. So I would make an endonasal approach and try to decompress as much as I can. But you know, even if you do that, in a few months, it will look the same or even worse. So you need another treatment option. What can be added? So I would talk to our oncologists whether they would initiate some kind of chemotherapy. I don't know, Temodal or some targeted therapy. I have no idea. I would look at typical markers which can be investigated in the histological specimens, but very strange case.
Marcos, any comments?
I have seen a number of such cases. If you have a pool of patients, you will have these extreme cases. They are very disastrous, and you may have excellent cases, excellent outcomes, and so on. All these groups belong to craniopharyngiomas. We still don't understand. Maybe the clue will be the molecular analysis of these tumors, and probably in future target therapies against them. But for the moment, the patient has a rapid growing tumor, is becoming blind. So in my hands, I don't know exactly precisely what everything has been done for him, but I would go through a transcranial approach. And I have done some of these cases. We could save visual function, but it's a very tough situation. So very tough situation. But I'm surprised, Henry, you have not seen that, but I have seen not few of such cases. Tomorrow we are going to operate such a case. So surgery a couple of times done, and rapid recurrence.
I have seen, Marcus, I have seen cases which got added radiation at other places, but here in Greifswald, places where we had the radiation are stable, and I've never seen a single progression.
Yeah, this is
so far.
And which kind is this LINAC IMRT technique or
LINAC?
Yeah. Yes,
Sebastian, comment? You are muted, Sebastian.
I have a bias because I know what you did, so but completely agree with Marcos. I have seen cases like this. It's not so often, obviously, but you have those very difficult patients where it come back after radiation and you run after the tumor. And I remember of a malignant transformation I have seen also. So there is no good solution. Depends on the patient, depends on your expertise. It's a borderline surgery, I would say, salvage surgery. So it's a very difficult decision to make, but why not if the patient is getting blind? But the biology of the tumor is very bad, definitely.
Sebastian, this is like chordoma.
Yeah.
You have nice cases to present in your conferences, and then you have very tough cases.
The ones that you put below the carpet usually.
Yes.
Emmanuel, any proposal?
No, it's the same reflection. I mean, we have some patient like that, and whatever you can choose, you will run after the tumor and the follow-up and the long-term outcome of the patient will be very bad. So you try to decompress, but you cannot remove all the tumor, and you don't have any more radiotherapy to do. So it's why we need molecular data. It's why we need molecular research, because perhaps it's one case. I don't heard about the histology. It's papillary. It's not a papillary.
Adamantium.
So very close, very soon we will have target therapy for those cases. So, but it will probably not work on huge tumor. We will need to reduce, and after doing other case, it's like atypical and aggressive pituitary adenoma. Some case it's like that. You remove the tumor as much as possible. You do radiotherapy, and the tumor recur, and so it's always difficult. But I have some case. I remember at least 2 or 3 cases, and the outcome was very bad at the end.
Thank you. Mahmoud, a comment? You are muted.
Yeah.
You are muted.
I completely agree. It's a very difficult case. And we know for craniopharyngioma, generally the first time is the best time. For this case, no, we cannot cure this patient. I will try probably endoscopic approach, and I will discuss with radiotherapy if there is other type of radiotherapy. I don't know, GK or proton therapy or something like that. But it's a very difficult case. Yeah.
So I would like to share with you what I have done. The patient was worsening, your vision was worsening, so something has to be done. Should it be a palliative surgery again, or should it be more aggressive? I will have placed again the slides I have shown previously. I am in favor in some circumstances for applying an anterior interhemispheric approach. This approach is not well commonly used, and I don't know why, because it's a very interesting approach. You don't disturb anything, you dissect the interhemispheric fissure, and you have an incredible access to many structures. I'll apply it, and I've shown that during the previous webinar for olfactory growth meningiomas, for planum sphenoidal meningiomas, with limited brain retraction, meaning that a tumor can be resected without any damage to the brain through a unilateral access. This is a case of tuberculum cell meningioma I have shown before, a unilateral access. Why I show that now is that for this case especially, I applied not a unilateral access, but a bilateral access with transection of another portion, opening of the forks, and you can see how wide you have an access to the anterior skull base and to this craniopharyngioma in this case. You can see the drain I put, because the patient has an hydrocephalus, I put a drain in order to have more relaxation of the brain. The sinus is transgressed above the frontal sinus. This is the anterior limit of the opening, but you spare all the bridging vein. This is the vein which is posterior to the area of transection. It's exactly an anterior transection of the sinus, maybe 3 centimeters away from its origin. And this is the view that you get to this anterior interhemispheric approach. It is not a subfrontal approach. It is an anterior interhemispheric approach. This is the area of the tuberculum cellae. You start to see the tumor. You see many microvessels feeding the lesions. And now you will see the left optic nerve, and you can see, due to the previous surgery, how difficult was where the adherences between the tumor, remnant and residue, and the optic nerve. But the dissection is possible. You can see a technique with 2 hands. It is extremely important in such adherences to work with both hands. in order to preserve all the microvessels. This is the optic chiasm, which is very laminated. This is not the right optic nerve, and the same dissection principle apply. So you have the full control of the optic apparatus, you have the full control of all the microvessels. You can open the cyst. This is the control of the carotid, which was difficult, and all branches due to the adherence with the previous surgery. Since the beginning, I planned to make 2 stages surgery. The first with an anterior interhemispheric, and the second through the previous one, which was a transfrontal. So I was aware that I will have a limit during my surgery, but I tried to remove as much as possible during the anterior interhemispheric approach. This is the view of the basilar trunk, accessed through a frontal access. This is progressively the tumor which is pushed in the surgical field. The tumor has to be divided, to be debulked. This is in the depth, the basilar trunk, but in the superficie, this is one of the limits of the tumor resection. This is the anterior communicating complex. And you see both A2, and my idea before starting was to divide the anterior communicating artery because both A2 segments were of the same side. Cutting, unfortunately, the anterior communicating artery here was not possible because the anterior communicating artery was so small that it was not possible to apply 2 clips. So it means that you have to work below the anterior communicating artery complex and then above. Working above, you can isolate all the perforating vessels. You have to spare, of course, all those vessels. And by this approach, again, you will resect the component through the lamina terminalis and so forth, which is in the 3rd ventricle. The tumor progress, resection progress, you will be able to see all the structures, the bulking, and what will happen. We have also to see what can happen, to show what can happen during the surgery. Just a small tear when separating the tumor from the arteries, a small tear at the level of the anterior communicating artery managed with the clip application. It was already on the table because I was prepared for this. ICG control, perfect patency of both A2 vessels. So the tumor was resected partially, but largely through an anterior interhemispheric approach. This is what was possible with the first step of the surgery. What is inside the sella is completely removed. This is the remnant after the anterior interhemispheric approach. This is the pre-op. This is the result after the stage 1 of this surgery. The stage 2 was again with the previous transfrontal approach. And the first thing I will see is the sylvius aqueduct that was exposed during the first step of the surgery. This is the sylvius aqueduct. And now the tumor again is progressively resected, aspirated, and separated from all structure. Of course, the hypothalamus, but what is extremely important is the sparing of all the perforators coming from the circle of Willis. One of the perforators which will be dissected and spared all over the resection. This is a full overview of the vessels in order to prevent any injury to the patient. And you will see now at the end, after for me what is a complete resection, the sylvian aqueduct and all the small vessel running along the hypothalamus. This is the postoperative control. It's always important to show also postoperative CT scan because you can observe calcification on CT scan. It is recommended that will not be detected by MRI. So the postoperative CT scan did not show any more calcification. This is the postoperative MRI, no true contrast enhancement. And you have also to analyze what you have performed during the surgery in terms of cortical disturbances. This is the result after the anterior interhemispheric approach in terms of flare abnormalities postoperatively. So I would like to share with you the interest of this, for me, very important anterior interhemispheric approach, which can be maximized if you divide the sinus. It's not absolutely something that has to be done in all cases. But when you have a very aggressive tumor, which is recurrent, you can have the possibility to handle the structures very nicely with a so wide opening of the interhemispheric fissure. This was another comment after all your talks. I already showed some cases after this approach, and I remain pro this approach.
Maybe one comment. We do use this approach for olfactory meningiomas. The difference is, however, for olfactory meningiomas, you can more of the sinus. For the craniopharyngiomas, you must go a little bit more basal. Otherwise, you have the genu of corpus callosum hindering your view. So what we do when we use the interhemispheric approach is I go with the frontal craniotomy to the midline. So I keep the option to go subfrontal or interhemispheric. So I have both options. Mm-hmm. Subfrontal is faster, easier, but you don't have a direct view to the lamina terminalis, angulated view. Interhemispheric, you have the advantage, as you have shown very nicely, direct view to the lamina terminalis, but you must dissect the anterior communicating arteries and so on. It's more time consuming, but very beautiful. Congratulations for the excellent result.
I agree with this case. Comment, and I analyze also the distance between the anterior communicating artery and the corpus callosum. And placing the bone flap again can be, as you said, a little lower, but on the other hand, depending on the tumor extension, when the bone flap is slightly higher, just cranial to the sinus, the frontal sinus, you have more access to the sphenoid component, the intracellular component. So you have to choose with the larger bone flap if you would like to go cranially or caudally behind the tuberculum cellae. So we have to adapt, definitely. Yeah. Any other comment or question to the panelists?
Enough craniopharyngiomas.
Yeah, for tonight.
It was a great webinar. Very impressive. Thank you to all of you for your involvement, your commitment to the skill-based section activities. I think we have a very dynamic activities, and Emmanuel have started a new way to interact between ourselves, daily interaction with the network. So I wish you a nice evening, and we have another webinar in 1 month, and it will be my pleasure to meet you at that time. So thank you so much to all of you, and see you soon. Stay safe in the meantime. My best wishes to all of you.
Thank you to all. Have a good evening. Bye.
Bye.
Bye-bye.